This is a talk on osteotomy rules. As you know, we have three rules for correction of the deformities with relation to the final placement of the bony fragments in the mechanical axis. In reality, this is going to be a cheat sheet to understand the role of translations in deformity correction in order to make it easy for. We all are aware of the importance of taking full-length X-rays and analyzing the specific angles, which begins with the Mikulicz line of the mechanical axis. It should pass through the center of all three joints. The important angles at the level of the knee are the MLDFA and the MPTA, which are both 87 degrees. Vast majority of the deformities we need to correct affect these angles around the knee joint. At the ankle, the LDT or the lateral distal tibial angle is 90 degrees and the lateral proximal femoral angle is also 90 degrees. The lateral mechanical axis also needs attention, and these angles must be well known and kept in mind while correcting deformities. The most important ones are the posterior distal femoral angle, which is approximately 83 degrees, and the PPTA, which is the posterior proximal tibial angle, which ranges from 78 to 82 degrees. The anterior distal tibial angle at the ankle is 80 degrees and not 90. These are more or less population normals, which should help us to correct the deformities. If the opposite side of the patient is normal, then we can use the angles which are present on the opposite side. We can correct deformities with either external or internal fixation as long as we keep these principles in. The rule 1 states that if the osteotomy is performed at the apex of the deformity and the hinge is placed on the center of rotation of angulation or the axis of correction of angulation, we get a good correction with no translation at the osteotomy site whatsoever. The good correction refers to correction with respect to the mechanical axis. So this is an example. This animation shows an idealized deformity of a tibia with the proximal and distal axis intersecting at the cora, which is center of rotation of angulation. The transverse bisector line of this angle is actually the axis of correction of angulation, meaning the hinges can be placed anywhere. If we place the hinge at the convex cortex and perform the osteotomy at the apex of the deformity and gradually distract in the concavity, we get a correction with a triangular shaped bone formation with a full correction of the axis and no translation whatsoever. This principle was used in this 65-year-old gentleman with a Varus deformity, the mechanical axis passing at hardly 15% into the width of the knee joint. An opening wedge correction was performed. This animation shows how we calculate. A full-length X-ray is taken, which shows the mechanical axis grossly deviated. We then draw the mechanical axis of the femur, then the joint orientation line of the femur. The angle over there, the MLDFA, is normal. We draw the tibial joint orientation line and the MPTA at 87 degrees and the distal tibial axis. They intersect at this angle at the cora, which shows us the extent of the deformity. The transverse bisector line of this angle is also the axis of correction of angulation. When the hinge is placed on the concave cortex, we can get a closing wedge correction. On the lateral cortex, we can get an opening wedge correction. So in this case, we choose the opening wedge hinge placement, and we want the axis to pass through the Fujisawa point, which is approximately 62%. The mechanical axis comes down to the virtual ankle. We use the hinge point at the level of the superior tibiofibular joint going to the virtual ankle and the real ankle to determine the amount of correction. This is very important when it is done acutely using platings. Gradually with external fixation like so, we can fine-tune the correction by increasing or decreasing the amount of distraction. Here the medial opening wedge correction has been done using the Elizarov fixator with the hinges placed accurately at the level of the apex of the. When gradually distracted, it regenerates a triangular wedge of bone and allows us to accurately correct. As you can see, there is no translation at the site of the osteotomy and the desired correction is. We can use this to also perform lengthening, where the osteotomy is at the apex of the deformity. The hinges are on the axis of correction of angulation, but instead of on the convex cortex, away from the convex cortex, as seen in this animation. The familiar axis, the axis of correction of angulation, and the hinge is placed away from the convex cortex to give us a trapezoidal shaped regenerate which lengthens as well as corrects the deformity without a translation at the site of the osteotomy itself, but the mechanical axis is well corrected. This is an example of somebody who had a growth arrest in child for whom we perform the osteotomy, place the hinges away from the convex cortex and get a shaped regenerate to give him a good. Rule 2 is the one which is most often employed for deformity correction. Here, the osteotomy cannot be performed at the apex of the deformity for clinical reasons, but the hinge is either really or virtually placed at the level of the axis of correction of angulation on the cora. We will achieve good correction of the axis, but some mandatory translation will occur at the level of the osteotomy. This is commonly done for juxta-articular deformities, that is metaphyseal deformities, and we perform these as translation osteotomies. This animation should show how we do this. The familiar axis of correction of angulation, the hinge is placed on the axis, but the osteotomy is done away. We see some translation at the osteotomy, but the overall axis. This is commonly done for correcting varus deformities at the upper end of the tibia, as in this orthopedic surgeon who had medial compartment arthritis with a significant varus. This animation shows the plan of action. This is a full-length X-ray is taken. The mechanical axis is drawn, which is deviated into varus. We draw the mechanical axis of the femur to ensure that it is not deviated from the normal. We draw the tibial joint orientation line, draw the MPT at 87 degrees, which is the proximal tibial axis. The distal tibial axis is the anatomical axis. They intersect at the cora. That's the center of rotation of angulation. A transverse bisector line is drawn, and we can choose the hinge points either at the closing wedge, which is the concave, or the neutral wedge, which is at the center, or the opening wedge, which is at the convex cortex. Here we choose the neutral wedge correction or the focal dome correction. Again, we draw the mechanical axis where we want it to pass, which is through the Fujisawa point just at the beginning of the lateral compartment to end at the virtual ankle. The angle between the hinge point, the real and the virtual ankles is the amount of correction we need. When done acutely on the table as a fixator assisted plating, we need to accurately calculate the amount, but when done gradually, we can fine tune the correction. So this is the osteotomy with a mild lateral translation of the distal fragment, a mild external rotation of the distal fragment, which shows up as a one cortex translation posteriorly. The Irizarry fixator allows us to give acute as well as sustained compression, which allows good bony contact, stability, early weight bearing. He could attend to his outpatient's department in 3 weeks. He resumed surgeries in 4 or 5 weeks. Here he is full weight bearing in 6, and the final X-ray shows full correction through the Fujisawa point. So therefore, in short, in an upper tibial varus, we translate the distal fragment. Femoral varus deformity, as in this young girl, with a significant MLDFA of about 104 degrees or so, with varus in the tibia and to correct the varus in the femur with a fixator assisted nailing. External fixation may or may not be well tolerated by young people in the femur. So the principle involved here is to medially translate the distal fragment to allow the axes to line up. Here the polar screws on either side of the nail help us to maintain this translation with a locked nailing. In the tibia you can see correction of the varus and lengthening, derotation with a of the distal tibia. This is how we can get a full correction of the axis like so. On the opposite side, a varus correction is performed with a mild translation of the distal fragment laterally to get the line up. The lower femoral correction is shown in this animation. So the axis of the proximal distal fragment coincide at the cora Using the cora as the hinge point, we perform the osteotomy away from the synovial cavity, and therefore we need to translate a little bit medially in order to get a good correction. This principle was used again in this executive who had a varus malunion of a supracondylar fracture. So a dome osteotomy was performed and a minimal medial translation helped to line up. So the thing to remember is that the distal fragment goes medially to the varus. Femoral varus deformity, we always translate the distal fragment laterally. That is because the cora in reality happens to be at the center of the femoral head. By doing so, we are able to line up the mechanical axis and not allow abnormal forces to go through the lateral compartment of the knee. So in the upper femoral or subtrochanteric varus osteotomies for correction of varus, we must always distal fragment laterally. This is another yet example of a young girl who had Gaucher's disease with a mild varus deformity in the upper femur and shortening. We have performed a subtrochanteric valgus osteotomy in which the distal fragment has been translated laterally. This allows invagination of the fragments into one another, increasing the stability of the construct. And then a distal lengthening is performed. This picture highlights the importance of trying to line up the mechanical axis through the center of the hip, knee as well as the ankle. If the distal lengthening of the femur is performed in line, it is very likely that the mechanical axis will pass through the lateral compartment of the knee. By laterally translating the distal fragment just a little bit, the axis now passes through the center of the knee. So this is her with a full correction of her deformities and equal leg lengths. The same principle can be used in dysplastic hips with avascular necrosis or any dysplastic hip in which we want to reduce the forces on the hip. Slightly different utilized. Here, using the principles of McMurray or Powell's, we will translate the distal fragment medially at the upper level. So this is a young girl with dysplastic hip with a significant lurch. We have performed a subtrochanteric osteotomy into valgus, but the distal fragment is translated medially. This reduces the loads on the hip by almost 30%. At the distal level, a devalgus osteotomy has been done with a very mild lateral translation of the distal fragment. This allows the axes to line up and go through the center of the knee. This is a young lad at the age of 19. He has a fracture neck femur and avascular necrosis. You can see the over. We have medially translated the distal fragment, brought the trochanter down by adducting the limb, distally lengthened the femur, and minimally translated the distal fragment laterally to line up his mechanical. This has allowed his Trendelenburg lurch to be abolished. His legs are equal, and 21 years down the line, he continues to be free from pain, has full range of motion in the hips with a good. The mechanical axis on the X-ray on the right is lined up in the center of all the three joints. On a closer inspection, there is some abnormalities in the appearance of the femoral head, which does not give him too much trouble. In a lower deformity, we need to translate again the distal fragment medially to help the axes line up. This is a 20-year-old chartered accountant with shortening and a varus deformity due to. Here we have, if we are to just lengthen, we will end up with an axis which doesn't pass through the center of the rotation of. So this animation explains how we analyze the deformity of the proximal and the distal axes which intersect at the cora. This is the axis of correction of angulation. If the osteotomy is performed a little away and the hinge is placed accurately, we will need to translate it a little laterally. Now these maneuvers can be performed either theoretically by accurately placing the hinges at the level so desired, or they may be placed virtually. That is, we choose the translations. We may or may not be able to place the hinges accurately because, as said, there is many a slip between the cup and the lip. And if the hinges are not placed absolutely accurately, the translation may not line up. So we can mechanically perform the translations to get the end result that we have in mind. So his axes line up in the tibia. So we remember to translate the distal fragment. In the lower deformities as in cubitus varus or the gunstock deformity, which is an unsightly cosmetic deformity. We also have to perform a slight medial translation of the distal fragment to line up the axes in order to prevent the ugly bump which is present on the lateral side. All these osteotomies are performed percutaneously through a 5 millimeter incision so as not to leave unsightly scars. This is his correction on the AP and the lat with good range of motion in the elbow joint. So in lower humeral varus deformities, we always translate fragment medially. Coming to deformities. Common ones are around the knee. This is a young girl with a valgus deformity in the upper tibia. Here we have performed the correction of the valgus with some lengthening, and you can see we have minimally medially translated the distal fragment. This allows us to translate the mechanical axis well into the center of the knee without having to perform more angular. Similarly, the same principles are used in this young engineer who has got significant valgus deformities due to hereditary multiple exostosis. She chose to perform her corrections only in the tibia. We had to ignore the valgus in the upper femur. For correction of the valgus deformities in the tibia, we translated the distal fragment medially at the upper level. And looking at axis alignment, we perform the necessary translations of the fragments to get the desired correction of the axis running through the center of the knee. 5 years after the surgery, she is happily employed in the US and is recently married with no problems in her lower. So we remember to translate medially in upper tibial valgus. Upper tibial valgus deformities like this malunion can be corrected in this basketball by minimally translating the distal fragment laterally. This allows the axis of the proximal fragments to line up. Coming to the commoner lower deformities of genu valgum, as in this lady from Sweden who had mechanical axis running through approximately 90 to 100% of her knee joints. The valgus was both in the femur and the tibia at hardly 7 degrees in the femur and 7 degrees in the tibia. Her surgeons in Sweden refused to correct it because a 1 degree error can be as much as a 15% error of. So we chose to perform this using a lower femoral valgus correction with an LRS fixator, which was removed quickly, and a tibial correction using the TSF fixator. The more away you are from the CORA, the more translation is required, as can be seen in this slightly higher osteotomy, which was necessary because of the LRS fixator. A lower osteotomy is usually possible using the Elizarov fixator because we can use pins both medially and laterally and stay very close to the source of the deformity. A similar principle was used on the opposite side. Dome osteotomy was used. The appropriate translations were used to get a good correction of these. When faced with genu valgum as well as shortening, we can also for correcting genu valgum with short, we can use the same principles as in this lad with growth arrest after osteomyelitis. Tailor spatial frame fixator to allow us to laterally translate the distal fragment as well as lengthen. Here we have over-corrected him a little bit to compensate for a little bit of. The principles of lower femoral valgus are outlined in this animation. With the MLDFA at only 71 degrees, we draw the anatomical axis of the proximal and distal fragments. The distal one is at 81 degrees. They line up at the CORA. The hinge point is placed away from the convex cortex. The osteotomy is performed away from the synovial cavity, and hence a little lateral translation is a must to get the axis to line up. So here he is with a little overcorrection, which was in an adolescent young girl who is obese. External fixation treatment would probably be less well tolerated. Hence, we use the same principles of translation but do the using intramedullary nailing. Here are high quality X-rays with magnification markers plan, and here are the steps of the surgery in which we use a guide wire over which we use thin walled to narrow the track of the nail and perform lateral translation of the distal fragment acutely with the help of the external fixation. The polar screws on either side of the nail help us to maintain this translation so that the axis lines up in the center, and then lengthening is performed with the LRS fixator. The fixator comes off in a few weeks, hardly about 4 to 5 weeks, and therefore she gets the possible very good resumption of knee function like so. So lower femoral valgus is always corrected with the distal fragment laterally. The extent of the lateral translation depends on how far the osteotomy is from the deformities. A fixed flexion deformity in poliomyelitis treated by a supracondylar also mimics a procurvatum deformity. Here is a lady 28 years of age with a significant deformity. This is a disabling deformity and it needs to be corrected. There is absence of quadriceps function and therefore we need to get the center of rotation of the knee. We need to get the center of gravity of the body to pass in front of the knee. A posterior translation of the distal fragment becomes a must. This is also necessary because of the principles of deformity correction. The rule 2 states that the CORA is at the level of the knee, but the osteotomy is done at the supracondylar level. Hence, the translation will be the distal fragment posterior. So here she is with good correction of her deformity and full range of knee motion. So lower femoral procurvatum, that is fixed flexion deformities either in polio or cerebral palsy or post-traumatic deformities can be corrected keeping this principle in mind with a procurvatum deformity of the upper tibia, on the other hand, needs a correction of the procurvatum with the distal fragment going anteriorly. This is a procurvatum valgus deformity due to a malunion in this gentleman who needs a good correction. So it shows the steps of analysis, the valgus, the procurvatum, and we have taken the oblique plane x-rays which show us the full extent of deformity and at right angles no deformity. This is the subtle deformity which is visible, which he insisted on. So we have the valgus is corrected by medial translation and the procurvatum is corrected by an anterior translation. This is what it looks like on the AP and lateral, but eventually these line up. So we remember to translate the distal anteriorly. Same principles for correction of equinus. The equinus can be equated to a procurvatum deformity at the level of the ankle when we correct it with a supramalleolar osteotomy, as when the talar dome is, same principle can be applied. Here is this lady with a residual equinus due to clubfoot in childhood, which is now troubling her with ankle arthritis. So this equinus is procurvatum, and we use the center of rotation of ankle as the CORA, but the osteotomy is done at the supramalleolar level. A fibular osteotomy is formed, and the distal fragment is translated posteriorly to allow the axes to line up. So lower tibial procurvatums, the distal fragment posteriorly. Procurvatum deformity of the knee, such as this one, which is a very troubling deformity. We need to percutaneously in the lower femur with a mild anterior translation of the distal fragment. Like so, this kind of translation allows us to get stability at the osteotomy as well as to get the mechanical axis to line up to allow them to. So lower femoral recurvatum is corrected with a distal fragment anteriorly. We finally come to upper tibial recurvatum deformities and calcaneous deformities ankle joint in poliomyelitis, as in this young lady who's a software engineer. This is a disabling deformity. The ankle collapses into dorsiflexion. This is a calcaneus, and we can use the principle to perform an osteotomy correction and translate the distal fragment a little anteriorly to allow the axes to line up. She also has correction of the varus at the upper tibia with this mild lateral translation fragment. So by minimally anteriorly translating the distal tibia, the axes of the two fragments line up and it helps in better passage of the center of gravity joint. So to sum up the distal fragment anteriorly. So this is a summary of the cheat sheet in which we use these translations to achieve the goal of correction in all deformity corrections